Um, in a bit, hopefully. My slides come up automatically. Oh, well, they do. Here we go. So I'm Rod Lawson, as we've heard. I've been a consultant in respiratory medicine in Sheffield for quite some time, including working throughout most of that time with the community respiratory teams and doing some community clinics. In theory, I retired a couple of years ago, but I can't quite escape. But here's a photo of some of my future plans, which I'm hoping to do more of, and we've got a photo of Kath as well. As I say, I am aiming to do less in the future. With that spirit, I am only going to give part of this talk and then shut up. The talk is about oxygen treatment and oxygen levels, which is, it sounds like it ought to be fairly simple, but it's something that's often, I think, not well understood, not well appreciated, either in hospitals or in primary care, and either by doctors or nurses or anybody else involved. There's often misunderstandings of principles as well as the practice. And what's really important when we think about this is thinking about both the individual patient and the setting in which they're being treated. And I don't mean by setting hospital or community so much as what the state of that patient is at a given time. But there are some important guidelines around this, and this is one of the key documents, which is the Acute Oxygen Guidelines, which is produced by the British Thoracic Society. But you can see the people who've signed up to that in terms of national societies, and includes a range of hospital specialities, including health care of the elderly, acute medicine, etc., and respiratory medicine, and it includes the Royal College of Nursing and the Royal College of General Practitioners. So it's an unusually broad set of consensus guidelines, and they're mandated for use anywhere where acute oxygen is delivered by the NHS, by an NPSA safety alert, which, as I say, is mandatory and binding on the NHS. And the main thing they talk about there within those guidelines is that oxygen should be prescribed to achieve a target oxygen saturation. So those put on the board that it's the effect that the oxygen's having that's important to achieve at the end that you want to achieve. And a really important thing, principle to start from, is that breathlessness and oxygen levels are not the same thing. So we've got here a flight crew who, if they cruise at a normal cruising altitude for a commercial airline, will have oxygen saturations of 90% or just a little bit lower. They won't be breathless, they won't particularly notice it, it won't affect their judgment or their thinking, they'll be fine, but they will be significantly hypoxemic. If we look at the Olympic rowers who've just won a medal, they've probably got normal oxygen levels, but they're as breathless as it's possible to be. If they weren't, they'd have rowed harder till they were. About 1/3 of Olympic athletes can force their oxygen levels down to just subnormal levels of perhaps 92, 93, 94. That's because they're abnormal and superhuman, and they can get such a high cardiac output that the blood goes whizzing through the lungs so fast that they can force themselves to be hypoxemic. That's an abnormal response. So that shows the disconnect between breathlessness and oxygen level. So that's an important principle to bear in mind. Within my working lifetime, things have got in some ways much easier because of the widespread adoption of pulse oximetry, and this has now got adopted pretty much everywhere. It means that you can get a measurement of oxygen level directly. Mostly it's fail-safe, so the reasons for getting an erroneous reading will mostly be because of poor tissue perfusion and things like atrial fibrillation, which may give you a false low reading. So it tends to be sort of fail-safe and encourages you to be more active rather than less. The exception to that is if there's carbon monoxide poisoning, when the reading will be falsely high and shouldn't be used at all in that circumstance. And it is occasionally possible to get false low readings, and that's more common in those with pigmented skins. The important thing, though, is that it doesn't give you a full assessment of blood gases, because you don't get any measurement of PCO2 and pH, which are important measures. Oh dear, oh dear. Which it's on the bottom, is it? How's that? Oh, there we go. Right, so it doesn't give you a measure of pH or PCO2, which if you want a complete evaluation of your patient, particularly with respiratory disease, you need those parameters as well. For instance, if you want to decide whether somebody might need ventilation, you need to measure those things as well. So oximetry is fine, but it will give you a limited evaluation. Now, we do know oxygen is good for you. If you don't have it, you die. So that's an easy concept. We don't need to discuss that too much further. But why don't we just give oxygen to everybody who's a bit poorly to be on the safe side? Well, if you give oxygen even to normal people, all sorts of things may happen. You can get atelectasis of the lung. You get formation of damaging reactive oxygen radicals. And then in those with respiratory disease, we may get CO2 retention. So particularly people with COPD, but those with chest wall disease and neuromuscular disease too. You'll get systemic vasoconstriction. You'll get decreased cerebral blood flow. So in normal people given hyperoxia, their cerebral blood flow will go down by 25%. You'll get increased systemic vasoconstriction, giving increased afterload for the heart, and you'll decrease the cardiac output by about 1/4 in normals. So all these things are quite bad. And because you've increased afterload, you'll decrease myocardial oxygen supply, you'll increase myocardial oxygen demand, and you'll increase the risk of cardiac ischemia by hyperoxia. So there's a lot of adverse physiology can be induced by just giving oxygen even to normal people. And if you think about somebody who's unwell, so for instance a patient who's got acute chest pain and might be having a myocardial infarction, giving supplementary oxygen will do all of the things that you don't want to do. You want a drug that will do the opposite of oxygen to improve their cardiac function and well-being. Does it match in practice? This is a study by Paul Plant from Leeds, which is quite old now, but they found that 47% of patients with COPD had a slightly raised carbon dioxide when they arrived in hospital, and 20%, so as many as 1 in 5, did have a respiratory acidosis on arrival. About 5% had a dangerous degree of hypercapnia and respiratory acidosis. And most of these well, a lot of those who had a raised CO2 and were dangerously hypercapnic didn't have a low oxygen level, which implies they'd been given too much oxygen in the first place, and that's what had precipitated that problem. So a lot of people in this study were getting given excess oxygen on the way to hospital. Here's a study from New Zealand. This looked before that point, so this is during transport to hospital in the ambulance. They had compared just giving people oxygen during transport, people with COPD, versus titrating and measuring with oximetry. And the difference that made is that if you're giving oxygen to targeted guidance rather than untargeted, you are less likely to die. So the mortality difference that was measurable, that was significant in just 400 people with that singular intervention. So I'm talking here about patients who are acutely ill, and I'm talking about the risks of giving too much oxygen in the context of patients who are acutely ill. So that's one end of the spectrum that we might be considering. If we change gear entirely and look at the other end of the spectrum, now we're talking about chronic patients. So these are patients who are not acutely unwell now, they're pottering along at home, but they are a bit hypoxic. And if they are significantly hypoxic and you give them long-term oxygen treatment, again, there's a mortality benefit from that. What I'm trying to say here is that there's a difference between a patient who is acutely unwell and their needs here and now, and what's safe and what's unsafe for them, versus the patient in their chronic state and what's safe and unsafe for them in the chronic stable state. And those are not the same things, and that's part of where the misunderstandings can flow from. And I'm going to now pass over to Kath, who's going to go into that in more detail and explain how we do with regard to that here in Sheffield.
Hello, I'm Kath O'Connor and I'm a physio. I'm not a doctor, and I work in ICT therapy, and I've got an announcement to make.
It's not that important. Don't be excited.
There is a grey Volvo blocking somebody in, YM69KPV. That's you. Thank you.
Thank you very much.
So I'm a physio working ICT therapy, and the reason I'm here is because I'm a respiratory physio. I only see respiratory patients, and I've been concerned that people haven't maybe been admitted to hospital when they should, when they've been hypoxic, or maybe haven't been referred to LTOT. So hopefully I'll get this right. Oops. Oh, where's she gone? Pressed the wrong button. This always happens to me. Oh, there we go. Yeah, it's gone right. So my concern was that people keep on saying to me, oh, it's normal for people with COPD to have low SATs, and it's just not. It's not routine. It's not normal for people with COPD to have SATs of 88 to 92 in the community, and that's despite what the patient tells you, because they might have been on a ward and they've had high carbon dioxide levels, and they've been told by somebody that your target SATs are 88 to 92, and they take with them forever, and their family take it with them forever. And so, yeah, they might have had that hospital target, but that doesn't mean it carries on for the community. And the other thing we've had is that somebody somewhere has written it in System 1 that they've got a target SAT of 88 to 92, and that's often, I'm looking at the COPD nurses in the back, it's often the oxygen nurses on the ward that have said this person's got high carbon dioxide levels, they've got a target of 88 to 92, and they've written it in System 1 whilst their person has been on the hospital ward. So what we're worried about is that's actually carried on into the community, when in actual fact, if you've got COPD and you're having an exacerbation, you should really be admitted according to the NICE guidelines if your SATs are below 90. And so we're finding that ambulance drivers aren't taking people in partly because the patient's telling them that they've got low SATs. GPs sometimes are saying, well, it's normal for them to have low SATs as well. Respiratory nurses, physios, everybody across the board. And this isn't just Sheffield, this is a national problem. And the other thing is we're finding again that people aren't being referred for LTOT, and I've warned the LTOT nurses, the oxygen team, that they might get an influx of referrals after today, because people who've got COPD should be referred for an LTOT assessment if their SATs are less than 93. And again, we're finding that patients are just being told that it's normal for them. They've got COPD, they should, normal for you to have low SATs. And that's life-saving treatment. I think Rod's last slide was how LTOT can save your life and it reduces mortality. On the other end of the scale, if you're really poorly and you've got COPD, there's evidence that you're more likely to die within the first 90 days after an exacerbation, and that's been linked to hypoxemia. So Rod was talking about the dangers of over-oxygenation. I'm worried about the dangers of under-oxygenation. So one of the things, I've seen this used quite badly on a number of occasions, is that the patient's shown this to somebody and said, well, it says here that I've got carbon dioxide retention, and I'm meant to have a saturate of 88 to 92 on here, and that is meant to be for who? Yeah, it's for the ambulance driver taking you to hospital. That's who it's for. It's given to the patient to give to the ambulance driver to say, Rod's figures of ambulances used to kill people on the way into hospital. We want to avoid that. But actually people are showing this to everybody and saying that I've got a target of 88 to 92. And that's just meant to be for whilst they're going to hospital and when they first get to A&E, whilst they're waiting to have a blood gas done. So, as we said, acute hospital targets. Rod's talked a lot about those lovely guidelines that say that you shouldn't over-oxygenate people. But actually, if you're not at risk of hypercapnic respiratory failure, your target sats when you go into hospital should be between 94 and 98. If you've got known COPD or another risk, and it might be neuromuscular disease or something like that, where you are at risk of hypercapnic respiratory failure, your target would be 88 to 92 whilst you're waiting for a blood gas. And then when you get the blood gas, then things might change. So in the acute setting, you have your blood gas done at admission for anyone that's got SATs of below 94%. And then if that blood gas finds that your carbon dioxide levels are normal, your target then gets changed. And we're finding that that doesn't always happen. Unless you've had previous type 2 respiratory failure where your target would stay 88 to 92 during the admission. If you have that blood gas done in A&E, and your carbon dioxide levels are raised, your target stays at 88 to 92. So it's in that very specific time and it's during admission. When you get home, you shouldn't be discharged until your oxygen levels are over 90%, hopefully. So other targets can only be set by a consultant after a blood gas has been done. This shouldn't be made up by anybody, so it's about making sure there's a senior decision maker involved. There should be 90 to 92 at discharge. And definitely, whatever you do, don't put the pulse oximeter on somebody's finger and ask them to take deep breaths, because all that does is gives you a very transient reading of 30 seconds of lovely sats of above 95, and then, for the next 23 hours and 59 minutes and 30 seconds, they're low. So it just gives a false picture, and we see people being discharged home, and we're looking on whiteboard and it says, well, they were discharged with SATs of 98 and we're finding them to be 88. And that's because they took a load of nice deep breaths before they came out. Because the patient wants to come home, they'll gladly do that for you. And so if they're still low at discharge, then they should be considered for temporary oxygen to wean them off. If they've struggled weaning, they'll come home, but they'll still have an assessment at 6 to 8 weeks to check do they still need that oxygen. And then if there's any risks, whether that's falls or fire or drug use or anything like that, those people will be brought to our respiratory MDT and we discuss them on a Wednesday morning to see, is it safe for that person to be sent home with oxygen? So we kind of recognised this was going on for quite a while, but nobody really had any figures of how often is this happening in the community setting, or in the hospital setting. So I did a small audit within ICT therapy, and it was just people who were under our care or nursing care in the community who were admitted to hospital with COPD, and that was between 2021 and 2022. And I just looked at the first 50 patients of that. There were a lot more, but I didn't have any resources to do the audit, so it was a bit of a snapshot. And what we found was that when people with COPD went into hospital, they should have had that blood gas done in A&E if their SATs were below 94%. So of our 50 patients, 43 of them had SATs below 94, and only 24 of those had a blood gas done. So we're talking about just over 50% of people who should have had a blood gas done in A&E had a blood gas done. And then, after they've had the blood gas done, those saturation targets should have been titrated to make sure they were at the right level. Now, some of them had had previous carbon dioxide retention in the past, so there's a slightly higher figure there that even though that they hadn't had the blood gas done, they were titrated to what we would consider okay for them at 88 to 92. But what it doesn't show is that those people that haven't had a gas, we don't know what their carbon dioxide levels are doing, and we don't know how acidic they are, how low their pH is, and it might be that they would have benefited from BiPAP. And we know, Rod's my figures man, but he will say to you that if you have 8 people have NIV who needed it, it'll save 1 life. Is that right for number needed to treat? That's right for number needed to treat from Rod. So you need to have that gas done, even if you've had CO2 retention before, because you might benefit from having NIV, the non-invasive ventilation, to save your life. So it's really, really important, which is why we're doing this today with you. We're doing it across the hospital, and hopefully we'll try and get the message out after a bigger audit, doing it nationally as well. We also looked at what was happening in community. Were we referring people through to secondary care if they were poorly and their SATs were below 90? And between the nurses and the therapists, there was only a small amount, because my audit looked at people who'd been admitted. But, you know, still 3 out of 6 got admitted to secondary care when they should have done, and then small numbers again for the LTAP, 3 out of 5. So we know it was a small sample, and it was only ICT patients, but the biggest problem, we only looked at people who went into hospital. So if we looked at all the GP patients, then we might cover some of those where the patient said, well, my target's 88 to 92, or we might have come across people who'd said to Yaz, you know, it's normal for me to be like this. It can only be set by that consultant. And we just weren't able to fully explore what happened to people who didn't go into hospital. So from this, we just want to make sure in the community and primary care that we're advising the right recommendations based on the guidelines. So people with stable COPD should be referred for LTOT if their resting SATs are below 93%, according to BTS guidelines. And people with acute exacerbation of COPD should be considered for urgent hospital assessment if their SATs are below 90% and they are symptomatic, and that's NICE guidelines. There's always going to be people that say, no, I'm definitely not going in under whatever circumstances, who then go in a week later because they're really poorly, you know, they've deteriorated down. And we say, you know, nip it in the bud, go in now, you know, and it's really hard because people have bad experiences in hospital. So that's why we say considered, you know, we can't force people to go in. And there's going to be people who are palliative as well. So it's not for everybody, but absolutely we should be considering it, because it can be life-saving, cutting down on strokes, cutting down on heart attacks after those exacerbations. We're making sure that people on their transport into hospital, they're given the temporary target, but that is pending ABG. And then the other thing that I thought was useful to include in here is that we also look at ambulatory oxygen therapy. The pulmonary rehab team at the back, who, if you've not been to their store, please do, otherwise Ursula will physically kill me. They would say to you, they pick up a lot of people who desaturate, because they're the first people who've looked at exertional oxygen SATs. So people should be referred for ambulatory oxygen if your SATs drop by 4% to a level below 90, and that's to improve their activity levels. So it'd only be prescribed if it's safe, so they're not going to fall, they're not going to be smoking on it. And also, when they do the walking test in the pulmonary function unit, they measure, has your exercise endurance improved and has your breathlessness improved? Because there's no point in giving it to somebody if it doesn't improve things, because the weight of the cylinder can actually stop you from doing more things anyway. So it's got to be improving people. And as everybody else has done an algorithm, I've done one too. And mine is just looking at, if you look on the right-hand side, is their resting SATs above 92%? If it's not, are they stable? And if they're not stable, then we're considering the 90%, and we're thinking about hospital. And then obviously we look at, you know, if they decline or palliative. If they are stable and their SATs are below 93, so 92% or below, then we're looking at LTOT. And if they're stable at rest, but they're not on exercise, then we're thinking about ambulatory oxygen. It's slightly different for COVID than it is for COPD. Happy to share this with anybody who wants one. I can email it to Andrew, who's the distro manager here, so I'm sure he won't mind that. But yeah, that's what we've done. We've doing lots of training with people to try and improve patients' understanding of target SATs, as well as health clinicians as well. And I'm just going to hand over to Rod to say thank you.
Thanks. So it is confusing, there's no doubt about it. Big message is, if you've got a patient who's stable at home and their SAT's below 93%, that's wrong, because with treatment, long-term treatment at home, that long-term treatment can be life-saving. So nobody should have SATs at below 93% at home without further thought. If they're left at home with SATs lower than that, either they're being neglected and they're going to die sooner than they would otherwise do so, which is bad, or it's an admission of defeat that because of their personal circumstances and their personal physiology, it is impossible to do better than that. So a lower target saturation in the community is an admission of defeat, and it's an admission of poor prognosis. So that's the big day-to-day message in terms of your usual patient on review. A lower saturation in the community, below 93%, which is not actioned by a proper long-term oxygen therapy assessment, is threatening earlier death than might otherwise occur. So all of the target saturations are wrong without a full assessment, and they are a compromise and an admission of defeat. If the patient becomes unwell, it's a different circumstance. The threat to the patient then is it's the what is it? The Goldilocks and Three Bears thing, isn't it? You don't want it to be too much, too little. You want it to be just right. You can't just give oxygen because there's the danger of over-oxygenation. You can't not give oxygen because that's also harmful. And you then have a particular set of target saturations that apply while the patient is unwell to cope for that. And if the patient is significantly unwell, you then need to know pH and PCO2 to know if the patient needs non-invasive ventilation. And as Kath rightly says, the number needed to treat to save a life is 8 in that circumstance. So if you had the choice of an acute ST segment elevation myocardial infarction or that situation, you'd take a heart attack every day. It's far safer. Okay, so as I say, it is a difficult, conceptually difficult thing, but the important thing is it's different between the chronic, stable situation and what you're looking at there, and the patient who is unwell now in front of you and is poorly. And don't mix them up. I hope some of that is clear between the two of us as a double act, but I'm sure we're happy to receive questions now or be buttonholed somewhere around informally after the meeting if people prefer.